some of the data on stenting, and that kind of slide in front of you summarizes a lot of the published, patency data that we see with lesion length as well as on follow-up at 1 and 2 and 3 years. And it's very obvious, as your lesion length gets longer, patency start to drop very quickly with stenting. But also it's important to realize that as you follow those patients longer, you see that the patency data also drops quite significantly. And if you see let's say if you take lesions less than 10 centimeter, you have a very good patency data at 1 year, it's almost in the 90% range. But then at 3 years, you go down all the way to the 60% range. If you take lesion in the intermediate zone between 10 and 16 centimeter, you can see the first year patency is 70% and goes all the way down to 50% at 3 years. And of course, as you get into the lesion length, which is over 15 centimeter, which I see all the time, and I'm sure you guys do see all the time, you see that the patency data can go from 70% that we have seen in the COBRA trial, even with adjunctive cryoplasty, all the way down to 25%. So there's a lot of problems, with patency issues, despite, the fact that in shorter lesions, angioplasty, stenting seems to be a good modality of treatment compared to angioplasty. And that's what reflects in the target lesion revascularization. We see that in the randomized SFA trial, and you can see in the FAST trial, the liver PPX or the resilient. In the shorter lesions, stenting seems to be doing a relatively good job compared to angioplasty. But as you cross that mark, in the intermediate and the long lesion, first of all, the data become less and less, and whatever we have from data shows that, stenting start to fail compared to angioplasty overall. So many reasons, of course, for that, and we know that the SFA is subjected to too many forces. You've seen the slide many times before. All the extension, contraction, torsion, compression, and flexion, all this contribute to these problems. And this is an example on cine. As you can see, the stent bending and the kinking is very obvious with knee flexion, especially in the adductor canal area. And so the reality is stents continue to carry a high rate of in-stent restenosis and loss of patency, which is very obvious in the longer lesion and intermediate lesion. It seems to work better than angioplasty in the short lesions. And the problem, however, that we encounter is the stent occlusions. Fractures remain a real problem. The biggest problem that I see in my own practice is retreating the in-stent restenosis. This is really a challenging problem. A lot of distal embolization. The majority of those comes as CTOs, and they are rarely just restenotic. Most of the time, they are restenotic thrombotic. Very high recurrence rate, and of course, the more stenting, the more loss of potential future surgical target. So, how to avoid really stent-related problems? In my practice, it's quite simple. We just don't do it as much, and we try to keep the vessel as intact as possible. And we try to use as much as we can atherectomy, and I'll show you the rationale behind that. So, we think about what is an optimal strategy in peripheral arterial revascularization. I think it all circles around this triad, of improving vessel mechanics and improving vessel compliance, as well as leading to, hopefully, less stenting, and less dissection. But also we need to always remember, we have the distal vascular bed. We need to try to protect that as much as possible. And we, of course, have the restenosis issue that we have to deal with, by altering vessel biology. So we believe if we can work around this triangle where we stent less, dissect less, protect the tibial circulation, and improve the vessel biology, we probably will end up with some form of an optimal strategy in treating PAD. And of course, atherectomy has been the mainstay in our lab, and we've used all those devices, the laser or the turbohawk for directional atherectomy, of course, the jet stream for rotational atherectomy, and the Diamond 360, as a rotational atherectomy device. And let me take you with some of the data that we've had. Initially we've done the angioplasty versus Silverhawk atherectomy trial. It was a prospective 2-center randomized study of PTA versus atherectomy. Primary endpoint was PLR, but we did look at the rate of bailout stenting for suboptimal acute angiographic results and looked at TVR. And it was a 58-patient study, randomized 29 patients in each arm, and the final acute angiographic success, were 100% in the PTA arm, 97.2% in the atherectomy arm. So when we look at the angioplasty versus the silver hawk atherectomy, you can see the probability of TNR survival was about the same between the silver hawk and between the POBA, even though it inched just a little bit better with the silver hawk. But then what we had is a very significant finding, which is the almost a 50% reduction in adjunctive stenting, which we have seen primarily because of less dissection and the residual narrowing was significantly less when we did that with the silver hawk. But the price we paid is, of course, embolization. As you can see, this is a spider filter, a large amount of embolus that you can get out of the atherectomy devices. And as you know, recently the spider filter was just approved, in FFA in calcified lung lesions, by the FDA. So now we can use that at least in femoral popliteal segment. As we can summarize that, there was no real change in TNR. There was clear-cut reduction in stenting by over 50%, and there was, however, very high rate of distal embolization, with the embolic filter protection seems to be quite effective in capturing those debris. If you look at the calcium 360 study, pretty much the same data. It's a pilot trial, 50 patients, randomized to orbital atherectomy and adjunctive POBA versus POBA alone. And if you look, it's a prospective multi-center. We had 10 centers in that study, randomized. 95% of them had severe and moderate calcium. And again, you look at, the freedom from restenosis, what seems to be better with orbital atherectomy. This did not reach statistical significance again. But you could see that the freedom from major adverse events was substantially less with orbital atherectomy versus the balloon. Orbital atherectomy clearly outperformed the balloon in that regard. The amount of pressure needed to stretch the vessel by getting a full balloon expansion was clearly much less after orbital atherectomy than just plain old balloon angioplasty, telling us very clearly that vessel compliance has improved. Again, the data that we see here is the dissection rate was much less after Diamondback, and bailout stenting was also significantly less when you see that after the Diamondback. So again, improvement in vessel compliance, less dissection rate. And you can see the TNR rate, seems to be significant, at least trending toward a much less rate of TNR, after Diamondback compared to POBA. But again, this is a small number of patients. We don't have statistical significance here. So again, after orbital atherectomy, trend toward lower TNR, lower dissection rate, lower bailout stenting, and higher freedom from major adverse events. The Compliance 360 trial did exactly the same as we have seen in the Calcium 360 trial below the knee. Again, prospective, multi-center, randomized trial above the knee lesions. The maximum balloon pressure after orbital atherectomy was significantly less than just using the balloon alone. And when you look at bailout stenting, it was markedly less with the orbital atherectomy arm compared to the balloon arm. So now we have 3 randomized trials, mind you, not very large, but they are all telling us the exact same thing. You do the atherectomies, whether you use orbital atherectomy or Silverhawk, at least with the data that we have, you have less dissection, you have less need for stenting, and at least from the Calcium 360 trial, there's a chance that there's going to be less major adverse events. So what about some of the smaller registries with other devices? If you look at the Pathway device, which is currently the Jetstream, this is the older generation, small study, 42 patients. You can see that the stent implantation was relatively low, 11%. Dissection rate was only 7%, embolization 4.8%, and again, 19% restenosis at 1 year. Small observational data, but it seems to be favorable. And currently we're doing the JET registry. As you know, it's a multi-center registry, 75 sites. The purpose is to enroll 500 patients. We're about 180 patients in that. And it's going to look into all these parameters, including stent rates, including patency at 1 year, and so forth. Now, let me give you some cases here just to kind of illustrate some of the points that I just mentioned. This is a 73-year-old male, severe claudication, ABI 0.55 at rest. He's treated with Silverhawk atherectomy. Look at this SFA, how heavily calcified, a very eccentric lesion. Essentially following just atherectomy using the TurboHawk and a 6mm spider filter, relatively good results, and then followed by adjunctive balloon angioplasty. You can see no dissection, excellent results overall. And this is really what you can get with atherectomy that you're not going to get with a stent. You put a stent there, and this patient is in the wrong location in the adductor canal. It's behind it. There's going to be a rock literally sitting. You know the stent is not going to expand very well, and you're going to deal with problems down the road. Again, embolization is always an issue, and this is the filter after you retrieve it. There's clear-cut embolization, especially with those calcified lesions. But again, this patient had no problems at all. The filter was very effective in capturing the debris. So this is a second case of a 72-year-old patient, severe claudication, limiting at 100 feet, smoker, hypertensive. Claudication started about 6 months prior to presentation. ABI is at rest, 0.7 with exercise 0.4. So you can see this is a lesion in a location that you do not also want to stent. As we know, this is the left common femoral artery. You get an ostial SFA lesion, and it's going right across this rotunda femoris. So this is a spot that we think is ideal for atherectomy. This is the runoff of this patient that looks really great. And we use the jet stream in this case. This is the jet stream device. And as you can see, right after jet stream only, without any adjunctive balloon angioplasty, less than 30% residual narrowing, very good results. And then if you do the adjunctive balloon angioplasty, you could argue, why did we even want to do that? Well, we always try to do some low-pressure adjunctive balloon angioplasty. And as you can see, the results looks excellent. Didn't have to put any stents, no dissections, nothing there. And this is an IVUS on that same patient. And you can see the arc of calcium between 3 and 9. This is significantly calcified, and you can see a lot of fibrotic tissue between 1 and 3. And following the treatment with the jet stream, you can see the fibrotic tissue is pretty much more than halfway gone. And as you can see, the calcium has been reduced significantly. So the lumen is much wider, very good results there. Well, let me give you a third case. It's an 82-year-old male, respiratory vector 4, resting pain, ABI is 0.4 at baseline, smoker, hypertensive, angiogram showing long, irregular, calcified SFA. Let me show you the pictures. Now, this is a lesion. You look at this and you say, oh my gosh, this is going to embolize everywhere. And, again, this is a long, calcified, irregular lesion. These are the type of lesions, we put filter in. And this filter is a NAV6 filter. We tend to use that a lot with the jet stream device because the wire and the filter are not stuck to each other. So the motion of the wire does not affect the filter. And as you can see, following just the jet stream itself, significant amount of calcium is removed. If you look at point between 18 and 20 on the ruler, and between 24 and 25, you can see the differences. This is following adjunctive balloon angioplasty, low pressure, 4 atmospheres. And again, this is the runoff. Looks very nice. This patient has a single runoff. Very good results in a very long lesion and a lot of irregularity and a lot of calcification. This is a fourth case, about a 65-year-old with right lower extremity claudication, Rutherford Becker 3, limited in his ability to ambulate, diabetic. And in this case, we have a CTO in the SFA. Now, this is a case where before we do any atherectomy, we have to make sure we're intraluminal. This is a case where, with crossing devices, the TruePad is what we use here. We like the TruePad. It has a diamond-coated distal tip. Usually it rotates at about 13,000 RPM. Very nice one-to-one torque response, that we see. The nice thing about it, you could also shape the distal tip. It's shapeable. I personally use that quite a bit in my lab. And I can tell you, following crossing, intraluminal crossing, we verified that. A filter was placed in, and I tend to use always the NAV6 filters and planning, doing the jet stream here again. And as you can see, this is the jet stream device. This is the treatment only after the jet stream and following adjunctive balloon angioplasty. I think you can all agree that this is very good results for not trying to put a stent in this location. Again, this is pretty much what we tend to do in most of those patients that we see. This is another case of a 72-year-old CLI occluded long anterior tibialis. Again, crossing it, orbital atherectomy, 1.25 diamond back. Very nice results. The runoff is maintained nicely. No need to for stenting, no dissections. So again, we look back into the optimal strategy in the PED, and we can see very clearly from all these cases, you can get very good results. You have very little recoil. You tend to have much less dissection. Vessel compliance is improved. And now with the embolic filter protection, whether the spider, which is recently approved by the FDA for FEMPOP use and calcified lesion along with the turbohog, or the off-label use of the NAV6, with the jet stream and so forth, you have a very good protection to the distal bed in a lot of these patients. Again, the vessel biology remains our biggest problem. And as you know, definitive AR is now in the follow-up phase, which is using a drug-coated balloon following atherectomy. So we will wait the results for that trial and we see what's going on. So bottom line is, this is kind of my practice. I believe that removing tissue and calcium to allow better drug penetration is going to be an advantage. I don't like the chronic stretching of the stents. I personally like to avoid high pressure balloons, and atherectomy will allow me to use very low pressure, very low barotrauma to the vessel wall. And again, we don't have a whole lot of deep tissue injury, and we lower dissection rate this way. I think this is the last slide I got, and I'm going to say thank you guys. I'll take all your questions.
Well, I think this is a good time to unmute your lines, and first of all, we invite each one of you to share your comments and questions. So if there are any questions, Dr. Shammas, please unmute your lines and ask it away, and Dr. Shammas will answer them as to the best of his abilities. Go ahead. And before you ask the question, if you can introduce yourself.
Dr. Shammas, this is Jaran Kumbani here. There was a really...
Hi, how are you?
Good. How are you? That was really an excellent talk.
Good, thank you.
I think it was very helpful. What is, when you, the question I have is, when you do infrapopliteal lesions for CLI, what is the largest bore size that you tend to use? Or what is your normal, and then what is the largest you go to?
Yeah, that's really an excellent question. Remember, with atherectomy, the purpose is not to clean every little plaque in the way. The purpose is to remove enough, calcium in tissue to alter vessel compliance. I tend not to oversize. I tend to actually stay with the, looking at the vessel size, assuming it's a 2 millimeter or 2.5 millimeter. I try to stick to about 70%, of the diameter of the vessel. Considering whatever speed you're using. So you have to kind of gauge the speed of the orbital atherectomy in that. But really the purpose...
Dharam, sorry to interject here. I think, Dharam, is your question regarding laser or during a particular atherectomy device?
No, atherectomy, just atherectomy devices.
I see.
Yeah. So, for instance, for the orbital atherectomy, I use, again, the 1.5 is a very common size. Sometimes, with the very mid to distal vessels, where the vessels become really small, even the 1.25, now we use. If you're in the proximal tibial vessels, if you're in the and you have a decent size, I use a lot the jet stream, the 1.6 device. I try not to go to the 1.8. I avoid that as much as possible. If it's a soft type of lesions, and you prefer to use the laser, that may work very well. I don't use the laser as much, but I do a lot of the orbital atherectomies in those calcified lesions or the jet stream, because I've seen a lot of impact on calcium in those vessels.
So the jet stream usually comes, I think the smallest bore size is a 1.6, is that right?
Correct. It's a 1.6 that doesn't have any blades up with those tibial sizes. The 1.6, 1.8 have no blades up. So you only get the 1.6, 1.8. If you look at the XC cutter for the FemPop, it comes in larger sizes, of course. So the 3 and the 3.4 is the beginning, with the two sizes up in the FemPop. But for the tibials, it's 1.6 and 1.8.
And I guess if you're doing this closer to the ankle, then you probably I think the 1.6 would probably be big in many people, right?
Yes, it would be. I tend not to go beyond the proximal to mid segment of the tibial vessels with the 1.6 or jet stream. If I'm going to get below in the mid and distal segment of the tibial vessels, I'm switching to probably a 1.25 diamond catheter, orbital atherectomy.
And can I ask one more quick question?
Please.
You and if anybody has experience, has there been any experience with using rotational atherectomy in the infrapopliteal vessels?
Yes, before orbital atherectomy days, I used to use rotational atherectomy all the time, and I can tell you what, it really does work. It is the problem, however, with the rotational atherectomy is the burr size and all that stuff. You don't have the advantage of the using the higher speed to get bigger sizes. So what happens is you really have to your sheath size has to be a little larger to accommodate the larger burrs that you are using. But again, it does work. It does work effectively, but it doesn't have the versatility and the flexibility of using orbital atherectomy, where you can gauge your sizes by the sheath.
Yeah, this is Drew Klein, and I want to follow you up there, Dr. Shammas, with that as well. Is that we are a big rotoblade lab, and of course Boston wanted us to try the peripheral rotoblade, and we'll use it if we have to, but it's you're really limited. But we generally will use a 2.25 burr or 2.15 burr.
Yes.
And it's only when you're really down into the small distal calcified vessels, and I really find it very niche. I prefer the CSI device. I agree with you.
Yeah.
Very similar practice patterns.
Yeah, very good.
I just want to open the question to everyone to opine, but the real question, the elephant in the room, is that when we talk about atherectomies, we kind of lump all these devices together. I think my question to Dr. Shammas is that, because he has a lot of experience in this area, that how does one choose one device over other, and what are the areas where one works better? Because the evidence base is really small. I think that this is a very important question, because each lab cannot have 5 atherectomy devices, and I think if you could each share some pointers that would guide the audience and the other operators of how to strategize and which to use when.
Yes, that's an excellent question. Absolutely, those devices are not born to be interchangeable in every direction. And in fact, you have to really know all these devices, and you pick and choose, to the situation that you're dealing with. For just to give you an example, for instance, when you're dealing with a calcified, clear-cut, heavy calcification. And I find, for instance, the orbital atherectomy devices seems to be, excellent in that regard. And again, you have to kind of tailor that to the lesion length. If you have a lesion excessively long and heavily calcified, you got to think about your runoff, for instance, and how much of that trash you're going to send downstream and the slow flow that may occur with this. So you may want to maybe potentially in that case, and I tend to go to, for instance, in a FemPop heavily calcified, I may very well end up with a jet stream device that I know very well works on calcium, but I tend to use filters with these. But again, in heavily calcified vessels, orbital atherectomy works excellent. The jet stream device, also now we're learning that it has excellent capability of removing calcium too. Laser, for instance, here don't do very well at all. A focal short calcified lesion, you could potentially use the TurboHawk. It works very well in that situation because you can do directional cutting to those areas of calcium, particularly if they are eccentric. You can direct your cutter toward that spot. But again, it depends on lesion length. It depends on the extent of calcium. It depends on the location. It depends on whether it's a complete occlusion with thrombus. For instance, if I see that, of course, you want to avoid any type of orbital atherectomy there, and the best thing to do probably is to go ahead and you have two options, either the jet stream that has aspiration capability. The laser may work very well in that situation too. So again, you're absolutely right. Every device is different.
Dr. Shammas, this is Drew Klein again. I wanted to ask you, what's your preferred option for in-stent restenosis?
Yeah, it's a great question. An in-stent restenosis is a favorite field of mine. If you remember, when depending on what we're dealing with, if you have a total occlusion in the in-stent restenosis, you IVUS those, and I'm sure you've done that several times. It's rarely just restenotic tissue. The majority of those are thrombotic/restenotic. And in fact, in the dethrombosis trial, we did IVUS systematic analysis on those, and it was very clear that thrombus is all over the map. And not only this, it's a different layers of thrombus at different ages, some organized, some fresh, and so forth. This is an area that I recently have been doing under embolic filter protection, jet stream, atherectomy. And the reason for that is and that's off-label, I have to be clear about that. Number one is because it has the aspiration capability. And number two, because it's a little easier to use. I don't have to do a lot of the directional cutting that I used to do in the old days with the tandem laser. But that works too, by the way. If you like the laser and you like the tandem laser, that works okay too. But I like the jet stream because it's fast, and at the same time, it has an aspiration capability. And if you use the technique, the 1 millimeter per second speed, and have an embolic protection device there, it works remarkably well. And in fact, we're doing the Jetstream ISR study right now. It's a registry that is ongoing, and we're hoping to finish this by June of this year. This will hopefully have some data on the effectiveness of the Jetstream, its safety, as well as some of the TLR data, and patency data at 6 months and 1 year. So again, this is currently what I'm doing.
Are you using a NAV6 with that, or are you using the spider? Because I've had issues with the spider binding up on the wire.
Absolutely, you're absolutely right. That observation is correct. The spider should not be used with a Jetstream device. And we've had the exact same problem as you did. We pointed that to Bayer and mentioned that to them. And in fact, another wire you do not want to use with the Jetstream is the Grand Slam wire. It does the exact same thing. The wires that we personally use with the Jetstream is the Spartacore wire. Works great. Or if we have to use a filter, we use the bare wire of the NAV6, which seems to be good. NAV6 is always my choice when it comes to the Jetstream now, because again, if you remember, you're doing the Jetstream, the wire, as much as you think that it's not going to move, and the way the device is designed to do that, interestingly, there's always some motion of that wire. And you want to make sure the wire is not stuck to the filter, so you don't move the filter with the wire at the same time. So NAV6 is ideal. The bare wire is good, and if you don't use filter, the Spartacore wire is an excellent wire. That's from Abbott.
Well, fantastic. Any other opinions on what are the preferred atherectomy devices used by other operators? There are a lot of operators joined in: Anand, Mazen, Dr. Gelati, Vishal, and others. Many others jump in.
Dr. Shammas, this is Mike Luna.
Mike.
Hi. How are you?
Good. Good to hear you. One quick question. As you know, most of the patients that we end up seeing in our lab are long SFA CTOs. And my question to you is, how often in those cases are you employing only non-stenting strategies and leaving just that? And if not so much, then what are you using to guide what segments to stent and which segments to leave alone with whatever non-stenting strategy you use? Are you using more IVUS? Are you using more angiographic appearance of the vessel?
Yes, that's a great question. CTO, as you know, we look at predictors for stenting. CTOs is one of them. And especially long CTOs. When you combine lesion length with a total occlusion, you certainly have a recipe for more suboptimal results overall, and the need for stenting. And that's actually well known to be one of the predictors for stenting. So the first question is, how often do we end up using stenting in those patients? Well, we just by the nature of the beast, these tend to be stented more frequently than of course, the shorter CTO and the non-occlusive disease. I don't have an exact percentage of this, but I would say instead of the normal stenting rate in all comers in our lab probably would be less than 20%. I would say those probably going to be in that 30 to 40% range. Now, what do we do? Well, we try always to get intraluminal. We try to always use some crossing devices, in these patients. If we are not successful with an initial attempt with the wire and the balloon, we're not very aggressive in the initial attempt, so we don't disturb the anatomy too much and end up subintimal and have to find the true cap and so forth. But let's say we ended up using some of those CTO devices. We get in, and if we feel like we are interluminal, and you as an operator, you'll probably be able to have a good sense if you're interluminal or not, depending on how easy it was, how your wire went through. If you have any doubt that you are interluminal and you're contemplating, using an atherectomy device, my suggestion would be to IVUS dose, and you would have a good idea where you are. We don't do that very often, however. This is an infrequent practice. We can tell, if you're going to be interluminal or not. One of the things that I do is I do use jet stream on those patients, but one thing I do not do is I do not use the blades up. Because if you happen to be in any section subintimal and you use blades up, you're going to have a higher rate of perforation. So I tend to use the blades down on those, and I don't have any problem with that whatsoever. When we do this, we rarely encounter any issue. So I think, if you cross with a crossing device or your normal way of crossing, you have a good feel that you're interluminal. I think, I would usually put in a NAP6 in those patients, and I do a jet stream blade down, assess the situation, and determine if everything is okay or not, and then go from there. Now, for the stenting in those, you can still end up stenting some of these people. So what I do is I normally do long balloon inflation, usually use 250 per 100 balloon, depending on that lesion length, if it's a real long lesion. Low pressure, long inflation. My inflation is always 90 seconds. I always repeat it twice. Sometimes, you look and you have to go even longer inflation, and sometimes we go in as far as 2 minutes inflation. But let's say you do all that stuff, and then you encounter only certain spots, where still there's some dissections or lumen compromise. I don't stent everything. I only stent spot stenting, and I only stent those areas that needs to be stented. And then I repeat the long-term balloon inflation, and I get by with a shorter stent that way. That's kind of the way I do it.
Any other comments, please, before we close the webcast?
Yes, if you don't mind, Dr. Shammas, hi, also from Dallas, Texas.
Hi, Tayo.
Hi. I wanted to go back to the below-the-knee vessels for a minute. Now that we have, longer and more flexible and perhaps, better drug-eluting stents, coronary drug-eluting stents, do you see a role for that in some of your below-the-knee vessels in terms of enhancing long-term patency?
Yes. Well, as you know, all the data on those drug-eluting stents, coronary application, all of this showed the potentially delaying potentially the TLR, improving patency, but the overall outcome of the patient when it comes to death and amputation really didn't make much of a difference. So in I do use them, and I'll tell you when I use them. I use them only when I have to stent, the proximal segment of the tibial disease, which is, by the way, very infrequent. I try to stay away from stenting as much as possible. I'm hoping one day we're going to be having the drug-coated balloon along with maybe the orbital atherectomy or whatever device we want to use, and end up with probably the optimal results without stenting. But nowadays, I limit these stents to only the proximal segment of the tibial vessel, and only in the case of a flow-limiting dissection. But I don't use them on a routine basis, just because the hard outcomes, of death and amputation has not really changed. And I'm hoping that I keep this vessel as intact as possible, to the days where drug-coated balloon will be available in the U.S.
Fantastic. Any other comments before we close? And this has been a fantastic presentation, Nick, and we hope to do this. I think every month the postings would be into your email boxes and also through the XLPAD website. So I greatly appreciate each one of you joining in. And before we close, I just want to give another chance for anyone if they have any comments or questions.
All right, Suresh, thank you so much. It's been my pleasure, actually.
Fantastic. Thank you all for joining. And I, again, want to thank Dr. Shammas for taking the time to explore all this important information and share this data with us. The recording of this webcast will be available on xlpad.org. Thank you all, and have a great day in the cath labs. Bye-bye.
Thank you. Bye-bye.